Okay, so the description of my fight to treat vasculitis from relapse back into remission, the problem areas are, and what I'm suggesting could be done to help myself and to help other vasculitis sufferers. We'll start off with what's vasculitis. And okay, we can see here in its simplest terms, if you take the word vasculitis, vascules, blood vessels, and it's an itis, it's an inflammation. It's a nice wee drawing here from the Sjogren's syndrome news. Vasculitis does have links to Sjogren's. Sjogren's does have links to vasculitis, but they're two separate things. But it's a nice wee diagram. You can see the inflammation here in the blood vessel causing a constriction of the blood flow, possibly even closing off the blood flow. But it's only in this location, and as you go further along the blood vessel, it's nice and normal, and that's vasculitis. You get inflammation at random locations along the blood vessel. Now, to expand on that, vasculitis is an autoimmune disease. Your immune system thinks there's something wrong with the blood vessel wall, and it generates an immune response to attack the blood vessel wall. It can be found anywhere that you have blood vessels. So anywhere. It's a rare disease, according to Vasculitis UK. It can be up to 3,000 new cases each year in the UK. And a typical GP could see one case every 5 years or so, according to this British Medical Journal document. And if we do the sums, that comes out with a percentage, which is some ridiculously small number with lots of zeros in it. Now, even though it's a rare disease, the disease itself has been split up into, well, depends on where, but it's got about 18 main named types. They're grouped by the size of the blood vessel involved, whether it's the largest one that goes in and out of the heart, or the other ones in between all the way down to the very smallest capillaries. It's grouped in that way, size of vessels, and then it's also grouped by the organ or organs impacted by the condition. And more details of that can be found in Vasculitis UK if you have a look at the fact sheet. Now, what about diagnosis? How's it diagnosed? Well, you get it one day, you're feeling not well. Think, no, something's not right. You maybe give it a few days, it's getting worse. No, this is bad. I've got to go to the GP. It's no good. Go to the GP. I'm feeling unwell. I've got a headache. I'm breathing something. Kidneys are not right. It's when I go to the toilet, it's something. Or the eyes are. I've got these red bits on the eyes, and it's painful. Hearing's going a bit dull. I've got this cough. Oh, fever. I can't. It could be anything. It depends on where these affected blood vessels are. It's really difficult to try and identify what the problem is. So the GP, he'll sound you off. He'll listen to your heart. He'll do a blood pressure test. He'll do this and that. He might grab some blood, send it off for a test. He may arrange for an X-ray, some kind of scans, depending on what he hears, what he sees, what he thinks. He might try giving you some medication that might help, maybe some nasal drops in case it's something to do, or maybe he may try some things himself. But eventually, he's not going to be able to diagnose it. So he'll identify the approximate organs involved, and he'll send you on to a consultant that's responsible for those organs. Once your appointment comes through, the consultant will see you, he'll do an inspection, probably more blood tests, probably set up more scans, gradually move to the more invasive, more painful tests later on. Start off with the things that are not too bad. You maybe get a spinal tap looking for cerebrospinal fluid, see what's happening in there. If that doesn't show anything, we head on to a biopsy, cut something out, have a look. Point they'll have found something because they're running out of tests at that point. So hopefully you get a diagnosis. Signs can show up early on. They can show up in the blood tests. You might see something in a scan. Biopsy, hopefully if they get the right chunk of material from the organ, they'll be able to see something. But although all of these tests can give some kind of indication, none of it's 100% guaranteed, so it can still be missed. Hopefully that's not the case. Hopefully you've been diagnosed without too much distress and they've come up with a name. You've got vasculitis. Congratulations. So after the disease has been named, you have a short-lived sense of reassurance, and then you start to realise, no, it's just a name, it's not cured yet. And this is when the postcode lottery starts. Which is crazy. Here in the UK, we have one of the most experienced authorities on vasculitis, Professor David Jane, Edinburgh Hospital, Professor of Clinical Autoimmunity, University of Cambridge. When you start digging into what's involved with this, you have a look at the worldwide trials, investigations, the experts. At some point, they pretty much always lead all the way back to Professor David Jane. The UK has got a massive resource here. In Scotland, we've also got recognised experts in the successful treatment of vasculitis, with locations in Edinburgh and Glasgow. Professor Neil Basu, he was in Aberdeen. He moved to Glasgow. I believe there's still a facility in Aberdeen that specialises in vasculitis. I believe there's also one in Dundee. I've not got the names handy. There is a name linked to that. Bean, as he prefers to be named, Nirajdan, and Duvcluth, they are in the Edinburgh Vasculitis Clinic. We've got expertise here, but we've got big gaps in between. So if you happen to live in the right area and happen to have organs that fall under the attention of nephrology or rheumatology, you may be seen by one of those specialists straight away. You might be lucky. If your health board's not in one of those areas, oh dear. The consultant controlling your care, they've got to figure out a treatment plan for you. Now, experience gained from potentially one case every 5 years and time is ticking. Permanent damage is accumulating. Well, what the consultant is going to do is they're going to try their best, but they'll maybe try the least dangerous treatment first and then wait for months to see the response. All the time, it's ticking away, the damage is accumulating. But they don't want to do anything extremely excessive, overshooting the mark. So they'll try and act on the cautious side with the hope of you seeing some kind of response, and then they'll maybe escalate it a bit, make it a bit stronger, try a bit more, do some time's ticking, the outcome's not so good. At the specialist vasculitis clinics, they could be treating, I don't know, I'm guesstimating 2 or more patients per week, maybe a bit less, maybe a bit more. But even if it is 2 per week, that's not a lot, but still much greater level of experience than potentially 1 every 5 years. Now, specialising in vasculitis, the consultants keep up to date with treatments that work and the ones that don't. They are up to date with this. They know what's going on. They share information. They're increasing the overall experience. They follow internationally recognised treatment guidance without delay. They understand delay is bad. And as an example, here's one NHS England. 2 hospitals listed here that have got a guide they've published online for the management of ANCA-associated vasculitis, with renal involvement in this case. So, taking vasculitis treatment into remission. If you're lucky enough to be treated at a vasculitis clinic, you may soon achieve remission. Good for you. Vasculitis is an uncurable disease. It can often successfully be treated in a timely manner if the correct treatments are received without delay. With delay and ineffective treatments, death or life-changing injuries are not an unusual outcome. Here's a story of Lauren's background. She didn't make it past the age of 15. Managed to contract a type of vasculitis called granulomatosis with polyangiitis. Her parents set up a charity in Scotland for vasculitis under her name, the Lauren Curry Twilight Foundation. They fund research into fighting the disease, finding cures. They raise awareness and they provide group meetings so that although it's a very rare disease, you get to know you're not the only one. There are others out there. The scary thing is there are so many others that have come across the same outcome from healthcare providers. So it's reassuring to know I'm not the only one, but it's scary to know there's lots of others. It's all happening the same way. The same mistake is being made for everyone. So what can we do? With vasculitis, you don't get a consultant of vasculitis. You don't get a consultant of vasculitis. The consultant controlling your care is a specialist in the organ that's got the problem in it, the organ that has these disruptive blood vessels in it. The consultant may never have successfully treated vasculitis. In fact, they may manage to finish their career in 20 or 30 years after seeing 5 or 6 patients with vasculitis and never had a successful outcome treating them. It's a rare disease. You can't expect every consultant to understand vasculitis. It's a rare disease. That's acceptable. If you look at the cancer comparison, what they've published is 1 year and 5-year survival rates of vasculitis patients is worse than most cancers. Some documents name typical types of cancer. like prostate cancer, breast cancer. In this case, they're saying worse than most cancers. British Medical Journal publication. Have a look at that. Once diagnosed with cancer, your care will be handled with a multidisciplinary team, according to Macmillan Cancer Support. Follow the link. It'll take you to more information. Now, transferring care to a multidisciplinary team, that would also work for vasculitis sufferers, and it would save lives. So, vasculitis, well, hey, it's the disease that just keeps giving. Now, remission is seldom permanent with vasculitis. Relapses are common. After one successful treatment, you would think that rapid treatment would be available when a relapse arrives, but well, from what I've seen, what I've heard of people experiencing, this just is not the case. Once remission has been confirmed, a relapse treatment plan should be set in place. Before you close up shop and go off to enjoy your peace in remission, before that all starts, you should set up a relapse treatment plan ready to go for when relapse will happen. When it happens, you need the plan in place ready to go. The local GP could play a part in starting the treatment plan. You've been fine for a while, a good few months, maybe a few years, and then, oh no, something's coming, oh, it feels like it's just coming back again. You go down to the GP, I think my vasculitis is back. Okay, let's take some blood, just make sure it's no some other disease sneaking in. We'll do the tests, and we'll get the ball rolling. Tests will take 2 or 3 days to come back, maybe. Take it from there, come back, see me in a couple of days. Okay, a couple of days, that's better than a couple of months. So you give the GP a chance to have a look at the bloods coming back, come back, yeah, there's nothing showing up in the bloods, it's the vasculitis again. We've spoke to the multidisciplinary team. The vasculitis specialist knows that your condition's back. He's confirmed that the plan's still valid. The infusion is ordered up. That's going to take a bit longer. It'll be another 2 or 3 weeks yet. But we're going to get you on high dose steroids just now. That'll hopefully calm the problem down a bit, maybe slow its progression. And once the infusion comes along as well, hopefully that will knock it back. So here's the prescription. Go and get them. Start them now. And we'll get this infusion course running as soon as we can. A letter will come out just to confirm it, but it's likely to be maybe the next 2 or 3 weeks. And there we go. It's surely if that was set in place, it would work. For a fact, delays in treatment lead to, well, you're going to have an accumulation of permanent damage, disabilities, the need for benefit support payments, things like that. Longer treatment durations as the diseases manage to achieve a stronger hold will mean more cost. It's going to be harder to treat because it's a more developed disease with more damage. It's going to take longer to come out of. It's going to cost more. You're going to have loss of workforce productivity because the person that used to be fully functional is now no longer to do some of the things they were able to do before. And the long-term drain on the NHS due to permanently damaged organs is also going to add to cost. If this isn't treated quickly, efficiently, it's going to be far more expensive in the long run. But here's the good news, a solution is already available. So what's needed to fix the problem? Well, we already have the experience in this country, and it's in the NHS. got a problem with a healthcare thing and you think, I'm going to go private, I'll jump the queue. No, vasculitis, the expertise is in the NHS. Now, okay, we know case levels are not high enough for specialist treatment centres at every hospital. Okay, that's acceptable, it's a rare disease, but a procedure or a rule or a dictate or some kind of enforcement of, once diagnosed with vasculitis, the patient's care must be under the supervision of a vasculitis specialist care centre, whatever form that takes. Could be supervised from another location if required. Use the cancer multidisciplinary team model. That will work. The medications, they're already available. There's no special difficult, you won't just nip into the pharmacist and pick all of them up, but generally speaking, they're not that unusual. Steroids and immunosuppressing chemo type drugs. They are only most effective when administered timely. The quicker you get the course running, the less damage is done, the less permanent, irreparable, irrecoverable damage is done. It's got to be done in correct proportions, the correct doses, and over the correct time spans. Now, an experienced vasculitis specialist needs to be in control of this part. Someone with experience, someone who knows if you move the dose of this a different way, if you don't join the two doses in parallel together, if the duration's not the right one, someone who knows. They need to be in charge of this part. Once in remission, the disease is going to return. You're in remission, that's great. Don't start celebrating until you've got a plan in place. Plan for its return. Be ready with a treatment plan put in place, something you can pop down to GP, you can set in motion. Or whatever it is, find out what the plan is. Get a plan in place. Make sure you know really how to start the plan. It needs to be there so that you can get treated efficiently, quickly, timely, the right way. Doing this will save lives. It'll limit permanent disabilities, it'll reduce strain on the NHS, it'll keep people in the workplace, and many other things. Okay, that's the problem I'm trying to describe. I believe it's easily fixable. It's not impossible. And if you make an attempt at it, and it goes in the right direction, you'll save lives. Go on, give it a try. Okay, thanks for listening to me.